Good afternoon, ladies and gentlemen. Thank you for the VNVDA for a warm welcome to Vietnam, and also thanks to Medtronic team for a great invitation for me to share my experience. Today, I will talk about the endovascular strategy for hostile neck AAA. This is my workplace. In the northern part of Thailand, we have two large hospitals that join to a group to treat the complex patient. Today, I will talk about the hostile neck and the endovascular strategy and will end up with case sharing from my experience. As we know that the EVA durability is depend on the adequate neck sealing. The sealing mechanism for the EVA include of the sealing and the sealing include the mechanism that the aortic graft attached to the aorta wall, and the fixation is the from some devices may use the hook to stabilize the device. In some devices use the anatomical like a sit of the endograft to the bifurcation. We already know from many reports and also in the guideline that tell us about the feature of hostile neck include the short neck, wide neck, angulated neck, conical neck, and thrombus neck that more than 2 millimeters. All of these features result in the type 1A endoleak, device migration, sac enlargement, and also increase the risk of further rupture in the patient that even we insert the EVA. From the data show that the hostile neck and wide neck increase much risk of type 1A endoleak and more likely to have a sac expansion. So there are many strategies to overcome this problem, include improve sealing and improve the fixation mechanism. To improve the sealing, we have appropriate device selection. Start with use the shorter start like this. It may better for conform to the neck anatomy that may not good for sealing at the proximal. And we will choose the adequate graft oversizing. And also we have some trip and tricks to deploy technique during the EVA procedure to improve the sealing. And if we think that the patient can live longer, we should consider to go higher for sealing. And for improve the fixation, we have the endo anchor device or ESA to fix the endograft to the aortic wall. So I would like to share my case that I do for the hostile neck. The first case is 77-year-old male with many past medical history of cardiac surgery and also have epilepsy. He presented with chronic anemia, and the hematologist tried to find out what kind of cause that make him anemia. And we found that he has a large aortic aneurysm that may cause some chronic DIC. You can see 10 centimeter of infrarenal AAA with severe angulated neck around 80 to 90 degrees. In this case, we plan to put the standard EVA device by use intraoperative adjunct technique. We have many techniques to overcome the angulated neck, include the use the C-curve for main body deployment and fixation first, put up reverse slider to make the graft attach to the greater curve nicely as shown in this picture. And in some surgeons suggest to use longer iliac limb to prevent the track down of the endograft. For this case, I start with the preparation for bilateral external iliac artery to improve insert the main body device on both sides. And then I insert the main body device followed by the angiogram, and I draw the neck here. For deployment, I start with deploy a couple two or one or two stent, and then slightly loosen the proximal suprarenal stent, and then use the push-up technique to push the endograft against the greater curve of the angulated neck, then followed by the Same step as standard EVA. As I mentioned before, I tend to use the longer iliac limb and push against the aortic wall to prevent the device track down from the neck. This this technique may help to prevent the proximal loss of the proximal neck sealing. And this is the final angiogram for this case that show the graph curve nicely to the angulated part and no type 1A endoleak. The second case was a 90-year-old male with chronic smoking and hypertension. He presented with symptomatic infrarenal AAA, and you can see that the neck is quite short from the renal artery, and the right renal artery has some stenosis and also have a small caliber of the external iliac artery. At that time, I'm already start the PMEC technique from Dr. Vira, and I try to use the endurance body to do two fenestration for bilateral renal artery. I do the 6 millimeter fenestration at the endurance body at the proximal part, and you can see that due to the short strut of the endurance, it limit us to do more than 6 or 7 millimeter for the fenestration. We do 6 millimeter for both renal artery and use the circular reducing tie to make it easier for cannulation. This case, we start with the first angiogram and located bilateral renal artery, followed by deployment the endograph until the fenestration open. On the right side, we fail to cannulate into the renal artery due to the fenestration is not at the inlet of the renal ostium. And on the left side, we can cannulate into the left renal artery, but we can't put any more device inside the left renal artery, even use many adjunct technique like balloon tracking, balloon swallowing, and also use the aortic balloon to place against the force of above. At that time, it was my early phase of practice, so I tried to insert a balloon expandable stent into the left renal artery by sheathless. But unfortunately, that you can see that the stent is dislodged from the balloon. So we have to capture the stent out to the 12 French sheet below. And I use the cells expandable cover stent instead in this case. The final angiogram show that we can preserve the left renal artery and there are some faint contrast go into the right renal artery. Even we cannot preserve the right renal artery, the case still go well, and we follow him about 2 years, still no endoleak, and even the renal, uh, the right renal artery is already occlude, the renal function is still good. So this is the learning point for me to do more and more on PMEC. The next case is 85-year-old woman that presented with abdominal pain, and she also has a history of lung cancer and also the COPD. You can see that she has a lung cancer here and in the arch, and also the visceral is look quite good. This case has a short neck, infrarenal aortic aneurysm size around 5 to 6 centimeter, and also have the tortuous iliac artery. After I learned a lot to do the PMEC, I try to use the PMEC in this case also. And you can see that the length below the left renal artery is only 2 millimeter. And if we go higher for just below the right renal artery, we can get more sealing. So at that time, I found the report about the FISA technique by do the single fenestration on the endurance body and used adjunct endo anchor for the contralateral side to improve the sealing and also the fixation. This case, I start with deploy the endurance body on table and do the simple fenestration 6 millimeter. on the endurance body for the left renal artery. We reinforce around with the double loop snare wire and use the circular reducing tie for easier cannulation. This is the final result for the device that we already modified. We start with the pre-cannulation of the left renal artery from below and then do the first angiogram, insert the main body device, and partially deploy until the left renal fenestration open. And then we deploy until the contralateral limb open and select into the contralateral limb to the fenestration, like shown in this video. After we finish select into the fenestration, we exchange to more stiff wire and fully deploy the stent graft by use aortic balloon to pop up the encircle reducing tie that we already do. And then we insert the long sheath inside, followed by the balloon expandable stent. After stabilize all the system, we proceed to do the endo anchor for the contralateral side and also at the above the location of the fenestration. And then we proceed to deploy the balloon expandable bridging stent. And this is the final result, show the good configuration of the stent graft, the endo anchor fixed nicely, and the final angio is look good without any endo leak. This is the fourth case. He was a 76-year-old male with many previous medical condition and also has morbid obesity. His body weight is around 100 kilograms. And he presented with juxtarenal aortic aneurysm. And you can see that at the arch level it look quite good. And then down to the visceral segment still has a straight aorta and the short neck or juxtarenal infra-aortic aneurysm. This case was my first case to do the full fenestration for PMEC. I invite Dr. Virat to help us. At that time, we start with the measurement of the fenestration and do the fenestration by use cable and also use double loop snare wire to reinforce around for fenestration. We insert one preloaded wire to the SMA and also use circular reducing tie by use 5O proline. And then we resheet the device. For the operative technique, we partially deploy and select into the visceral branch by branch, start from SMA to the bilateral renal artery. After that, we complete deploy and pop up the reducing tie, followed by insert the bridging stent for all visceral branch. And then we do the standard EVAR step. At that time, we use the flare limb because we don't to prolong the operative time, and the final angiogram is look quite good. We follow this case up to 2 years, and then the 1B endoleak occur on the right limb. You can see that at the first year is still sealed at the common iliac bifurcation, but after 2 years, the stent and move up and the common iliac on the right side is progressed, so the 1B occur. I put the coil into the internal iliac and extend the external iliac, maybe around previous 2 months, and after we follow the CTA, it look quite good. Until now, we do many cases of PMEC for both to the internal iliac artery for the PMEC for the visceral branch and also do on the arch also. Until now, we already get around 40 cases of the PMEC for visceral branch. For my conclusion today, I think the proximal neck is one of the cornerstone for EVAR surgery, and successful in EVA, we have to improve the proximal sealing and also the fixation. For the sealing, as I mentioned before, there are many techniques to overcome the hostile neck problem, include the device selection, good graft oversight, use many adjunct deployment technique, and also if we think our patient can live longer, you can uh, select the patient to do the ceiling more higher than infrarenal level, like maybe do chimney, CMD, or maybe PMEC. And for improve the fixation, we also have the ESA that I already showed for the FISA technique. Thank you for your attention.